Clinical chemistry, diabetes, pathophysiology, and diagnostic correlation. So to talk about and understand diabetes, we need to know a little bit more about carbohydrate metabolism. So the fate of glucose depends on the metabolic needs of the body. Energy production, the conversion to CO2 and water. Storage, glycogen in the liver, triglycerides in adipose tissue. So if we bring glucose into the body, it can either be used in energy production, and then it gets converted to carbon dioxide, which is exhaled, and water, which is used in the body. Or it can be used for storage. The way that we store most of our glucose in the body is going to be as glycogen, and glycogen is stored in the liver, and then also skeletal muscle can store some glycogen. And then triglycerides. We can convert glycogen to triglycerides, and those triglycerides can then be stored in adipose tissue or fat tissue. The conversion to keto acids, amino acids, or protein. So if we need certain types of amino acids in the body, we can put the glucose and break it down into acetyl-CoA, take it through the Krebs cycle, and from the Krebs cycle, there are intermediates which can be converted into amino acids. And then carbon, hydrogen, and oxygen metabolism is interwoven with that of lipids and amino acids. And that's all dependent on that central cycle of the Krebs cycle. Some of you may know it as the citric acid cycle or TCA cycle. So when carbohydrates are ingested, salivary amylase and hydrolyzes the starches. So salivary amylase breaks the bonds to break down the starches into smaller saccharides. So either disaccharides or monosaccharides. That salivary amylase is inactivated by gastric hydrochloric acid. But then in the duodenum, pancreatic amylases hydrolyze the partially digested polymers into intermediate-sized glucosans, and that's further digested by maltase, sucrase, lactase, and all sorts of other specific enzymes that have the capability of breaking down disaccharides into monosaccharides. Once monosaccharides are formed, they can be absorbed, and they can be absorbed through the small intestine wall into the bloodstream, which then routes those to the liver. Glucose transportation is regulated. The initial event is facilitated by transport across cell membranes. Intestinal sodium-dependent glucose transporter. Glucose transporters are abbreviated GLUTS, and they're integral membrane glycoproteins on the cell surface. So this is a table that breaks down GLUT1, 3, 2, and 4 into where they're most often or most commonly found and what specifically they do. So you can take a look at this table and review through all of these details. So pathways of glucose metabolism. Glycogen. So glycogen is the storage form of glucose, and as I mentioned previously, that can be found in the liver, or some glycogen is found in our skeletal muscle. If our body is low in glucose, what we can do is we can break down glycogen through the process of glycogenolysis into glucose 1-phosphate. Glucose 1-phosphate can then, if we need to turn it back into glycogen, can go through the process of glycogenesis to create glycogen. So if glycogen is getting broke down, glycogenolysis. If it's being created, it's glycogenesis. Now, many of these terms are going to start to look and sound the same, so you want to be able to break down the parts of the word to deduce their definition. So glycogen means glycogen. Lysis. Lysis means to break apart. So glycogenolysis is to break apart glycogen. Genesis is the creation of. So glycogenesis is the creation of glycogen. We can continue down on this pathway here. So glucose can be converted to glucose 6-phosphate. Glucose 6-phosphate can then be converted to glucose 1-phosphate, and that's how we get glycogen. But glucose can be converted to glucose 6-phosphate, which it can also go through the uronic acid pathway to produce glucuronic acid, or the hexose monophosphate shunt to produce ribose and CO2. Glucose 6-phosphate can also be converted to pyruvate and then go down through the process of glycolysis and continue down through the TCA cycle or the Krebs cycle or citric acid cycle, if you refer to it as that, and be converted to carbon dioxide and water. Pyruvate then has the ability to be converted to lactate. So if there's not enough oxygen, we're going to slip into anaerobic respiration, where oxygen is a deficit and we need to produce some type of molecule. So the pyruvate gets converted to lactic acid, and then it goes through that lactic acid cycle. Pyruvate can also go through the process of gluconeogenesis. Gluconeogenesis. So we talked about genesis being the creation of something. Neo means new, and gluco is referring to glucose. So it's the creation of new glucose. And what are we creating new glucose from? Pyruvate. Well, how do we get to pyruvate? We can, through the Krebs cycle, we can use fatty acids and we can use amino acids to produce intermediates that would allow fats and amino acids to be converted to glucose, and that's the process of gluconeogenesis. So we can regenerate glucose that way. So the conversion of glucose 6-phosphate, or G6P, is the major intermediate in glucose metabolism. Hexokinase is the enzyme that does it in most cells, but glucokinase does it in the liver and pancreatic beta cells. It serves as a starting point for glucose metabolism in the 4 major pathways: glycolysis, the hexose monophosphate shunt, glycogenesis, and the uronic acid pathway, as we saw on the previous slide. Then it's converted back to glucose by glucose 6-phosphatase. The enzyme is not found in skeletal muscle, though. So here's a breakdown of the 4 major terms that I defined previously. So glycolysis means breaking down glucose. If we say it fast, glycolysis, that's a familiar stage of cellular respiration. Gluconeogenesis, that's the formation of glucose 6-phosphate from non-carbohydrate sources, and that accounts for the maintenance of blood glucose when there's a prolonged fast. Glycogenolysis. Glycogen is converted to glucose for energy, and it's the maintenance of blood glucose with a brief fast. Glycogenesis. Glucose is converted to glycogen for storage. So this is what glycogen looks like. You don't need to know the exact structure for this course. You just need to know in general what glycogen is. And glycogen is a polysaccharide. So glycogen, there's many building blocks put together to make that polysaccharide structure. Ketone body formation. So fasting conditions or with impaired carbohydrate metabolism, a supply of acetyl-CoA exceeds oxaloacetate. The excess is mobilization or degradation of fatty acids. Ketone bodies examples include acetoacetate, beta-hydroxybutyrate, or acetone. This is reversed by carbohydrate ingestion or insulin administration. If we kind of summarize this into more simpler terms, we form ketone bodies when we're using fat for metabolism instead of glucose. So sources of blood glucose: dietary, gluconeogenesis, and glycogenolysis. So dietary is when we eat a meal. So you can see breakfast, lunch, and dinner, you'll see a spike for those meals. Gluconeogenesis, that's a prolonged fast. Usually overnight, we have a prolonged fast because we're sleeping and not eating. So that's when gluconeogenesis is going to take over. And then we're going to see occasional spikes between meals here. where there's a little bit prolonged fast because we're going 4 or 5 hours without eating. Glycogenolysis, you're going to see big spikes to try to carry us through those meals. The hormonal regulation of blood glucose. So insulin decreases blood glucose, and it doesn't just do so through one mechanism. Insulin has profound effects on the body, and it impacts blood glucose levels in many different ways. So it prevents more glucose from being created. It takes the glucose that we have and helps get it into our cells. It helps to get rid of excess glucose in the blood through secretion. It decreases digestive system absorption of glucose. So many different ways that it can do that. Counter-regulatory hormones increase blood glucose. So counter-regulatory means that it goes against the action of a particular hormone. So if insulin decreases blood glucose, counter-regulatory hormones would increase blood glucose. Glucagon, epinephrine, cortisol, and growth hormone are going to increase blood glucose. Normal distribution of blood glucose depends on the ability of the pancreas to secrete insulin, the ability of insulin to promote glucose uptake by peripheral tissues, and the ability of insulin to suppress hepatic glucose production. So the pancreas has to make the insulin has to be effective in the tissues, and the insulin has to tell the liver to stop producing more glucose. All of those three things have to happen in order for insulin to be effective. And this is where we kind of get into the conversation of diabetes. So in type 1 and type 2 diabetes, we will be going through these in more detail as we get through here, but just kind of like foreshadowing what's coming. The ability of the pancreas to secrete insulin has more to do with type 1 diabetes. So typically it's an autoimmune disorder of the pancreas, so that insulin's not really produced at good enough levels or high enough levels. The treatment for that one is typically insulin injections or taking insulin medication or insulin supplements. Type 2 diabetes has more to do with the ability of insulin to promote glucose uptake by peripheral tissues. So when we have a type of insulin resistance or the cells and tissues aren't really reactive to the insulin, that's more associated with type 2 diabetes. Now we can treat type 2 diabetes with insulin supplements or certain types of medications that are designed to help make insulin more effective. But a lot of times that type is due to obesity. So typical diet and exercise plan would be our primary treatment mechanism for our type 2 diabetes. Main targets of insulin would be the liver, skeletal muscle, and adipose tissue. And the response to insulin differs depending on the glucose transporter that is expressed. So insulin as a protein, it's a 6 kilodalton protein. You do not need to know the size of that protein or how many amino acids are in it. It's just for your information. It's produced by the beta cells of the islets of Langerhans in the pancreas. That is something very important that you do need to know. It's an anabolic hormone which stimulates the uptake of glucose into fat and muscle tissue. It promotes the conversion of glucose to glycogen or fat for storage. It inhibits the production of glucose by the liver. It stimulates protein synthesis, and it inhibits protein breakdown. So one of the new diet things that's going around these days is intermittent fasting. So what happens during a fast? Well, during a fast, especially if it's a prolonged fast, your body needs a supply of glucose. So if you're not consuming the glucose in your diet, then how does the body get the glucose that it needs? Well, during a prolonged fast, it goes through that process of gluconeogenesis. Gluconeogenesis is the creation of new glucose from either proteins or lipids. So during a prolonged fast, your body's actually going to want to break down your lipids or break down your fat in order to convert those fatty acids into a precursor of glucose, and then eventually it can be converted to glucose or used for cellular respiration. So that's why they're saying that this intermittent fasting is a good thing. So when we do have prolonged fasting, like I mentioned, we are going to decrease the availability of glucose, which then leads to that gluconeogenesis. The synthesis of insulin. So it's synthesized at pre-proinsulin, and that's typically not found in circulation. It's then enzymatically cleaved and converted to proinsulin. Proinsulin is stored in secretory granules in the Golgi of beta cells, 10% of activity of insulin, and it's the major storage form of insulin. Proinsulin is cleaved to insulin and a C-peptide. Insulin and C-peptide are released in equimolar concentrations or amounts into the portal circulation. C-peptide seems necessary to ensure the correct structure of insulin. And then excess is removed and excreted by the kidney. Counter-regulatory hormones are catabolic hormones. Catabolism, catabolic, is breaking down. If you think of like a catastrophe, it breaks things down usually. If we consider a tornado a catastrophe, that's breaking things down and breaking things apart. So catabolic hormones are going to break things apart or break things down. Increased the hepatic production of glucose. So we take the glycogen, break that down to release glucose into the blood. The initial response to low blood glucose within minutes is increased production stimulated by glucagon and epinephrine. With time, or 3 to 4 hours, growth hormone and cortisol increase glucose mobilization and decrease glucose use. Other hormones, neurotransmitters, are also involved. They appear to relatively unimportant, provide redundancy to the system. So here's glucagon. You do not need to know the size, but you do need to know where glucagon comes from. So glucagon is secreted by the alpha cells of the pancreas. Its major target is the liver. Minor target would be adipose tissue because it increases lipolysis or lipolysis, breaking apart lipids. The secretion regulated by the plasma glucose levels. So if we have low blood glucose levels, we would want to secrete glucagon to increase those blood glucose levels because glucagon breaks apart glycogen to release glucose into the blood. So if we have low glucose, that means we need more glucose in the blood. Glucagon is going to be active. If we have high blood glucose, then we don't want to have more glucose pumped into the blood or broken down and released into the blood. So that's when glucagon levels are going to be low. It's also stimulated by stress, exercise, and amino acids. So if you're stressed, your body needs energy to maintain that stressed out state. Sounds kind of funny, but that's what the body needs in order to maintain your stress levels. So short-term stress can help you lose a little bit of weight. You're going to be breaking down fats and converting proteins to glucose through the process of gluconeogenesis. However, long-term stress means that your body is going to actually want to prepare for those stressful events in your life. So anything that you eat is going to be extra stored in the body. So you're going to start to absorb a lot of nutrients from anything that you do eat and store that in the body. And typically it's going to be stored as fat. And that's all mediated by the different metabolic hormones that you have. But prolonged stress, bad. Short-term stress, it is helpful with losing a little bit of weight, but obviously nobody wants to be stressed. And then its secretion is also inhibited by insulin. So if we have too much glucose in the blood, we're going to release insulin, which is going to decrease the blood glucose levels. If we have not enough glucose in the blood, then we would release glucagon, which would then increase blood glucose levels. Those are counter-regulatory hormones, so obviously we don't want to release them at the same time. That would waste a lot of energy for us because one is trying to increase, the other is trying to decrease, and they'd constantly be fighting against each other. So we would release insulin during times when glucose is high and release glucagon during times when glucose is low. An impaired response to hypoglycemia with long-standing diabetes mellitus. High concentrations contribute to hyperglycemia and ketosis of diabetes. Epinephrine. Epinephrine is a catecholamine that's secreted by the adrenal medulla. It stimulates glycogenolysis, glucagon secretion, and it decreases glucose use and insulin secretion. Secretion is impaired with type 1 diabetes. Key role for glucose counterregulation with glucagon, regulation of lipid metabolism. Glucagon and epinephrine activate hormone-sensitive lipase in adipose tissue, in coordination with activation of gluconeogenesis in the liver. Metabolism of fatty acids through beta oxidation in the liver yields ATP for gluconeogenesis. Acetyl-CoA is converted to and released to the blood as ketone bodies. Other hormones include growth hormone and cortisol. Growth hormone is polypeptide that's secreted by the anterior pituitary gland. It stimulates gluconeogenesis and lipolysis, antagonizes insulin-stimulated glucose uptake, and the action is mediated by somatomedins A and C. Cortisol is secreted by the adrenal cortex in response to the adrenocorticotropic hormone, ACTH. ACTH is released by the anterior pituitary gland. Cortisol stimulates gluconeogenesis, increased breakdown of protein and fat. In Cushing's syndrome, hyperglycemia is noted due to increased production of cortisol by tumor or hyperplasia of the adrenal cortex. So hyperglycemia means high blood glucose levels, and that's because you have a lot of cortisol being produced, either by a tumor or by overgrowth, so hyperplasia of the adrenal cortex. Addison's disease is hypoglycemia that's noted due to the loss of cortisol that's caused by the destruction or atrophy of the adrenal cortex. So Cushing's syndrome, too much cortisol, that leads to hyperglycemia. Addison's disease, not enough glucose in the blood, not enough cortisol being released. Thyroxine is secreted by the thyroid. This is T4 of the thyroid hormones. So our thyroid hormone is T3, which is triiodothyronine, and T4, which is tetraiodothyronine. Iodo refers to the need for iodine in order to produce those thyroid hormones. So thyroxine is the tetraiodothyronine or T4 hormone of the thyroid hormone. It is secreted by the thyroid. It's not directly involved in glucose homeostasis, but it stimulates glycogenolysis and increases the rate of gastric emptying, intestinal glucose reabsorption. It may produce glucose intolerance in thyrotoxic individuals. Fasting plasma glucose levels are usually normal. Somatostatin is a growth hormone inhibiting hormone found in the GI tract, hypothalamus, and the delta cells of the pancreas. There is no direct effect on carbohydrate metabolism, but it inhibits the release of growth hormone, glucagon, and insulin by the pancreas. So then this is just a diagram that kind of shows you glucose, epinephrine, the islet cells, alpha, delta, beta cells, how somatostatin has a negative regulatory effect on the alpha and beta cells, and it's released by the delta cells. And then you can see the positives and negatives of what each hormone does. This is a really helpful diagram for the visual learners because you won't only need to know about these hormones for this portion, but especially once we get into talking about the endocrine system, you're going to need to know the impact that the hormones have on different processes within the body. So make note of this. You can definitely take notes and make flashcards if you learn better that way. Otherwise, the visual learners really like the diagrams. So go ahead and feel free to take a look at this for a while. So hypoglycemia, it's difficult to define the lower limit, but a transient decline may occur 1.5 to 2 hours after a meal. Concentrations as low as 50 mg per deciliter may be observed 2 hours after the ingestion of oral glucose load. Symptoms vary and none of them are specific. Trembling, sweating, nausea, rapid pulse, lightheadedness, hunger, epigastric discomfort. Central nervous system symptoms typically don't start unless the levels are less than 20 to 30 mg per deciliter. Neuroglycopenia means that there's not enough glucose and it's impacting the neurological system. Headache, confusion, blurred vision, dizziness, and more severe consequences include seizures, loss of consciousness, and even death. Neonatal or infant hypoglycemia. So neonatal glucose is lower than in adults. The average is 35 mg per deciliter. It declines shortly after birth due to the depletion of liver glycogen stores. So they're no longer what I call hooked up to their mom. They've been delivered and they use up all of the glycogen that was stored in their liver. So then they're dependent on replacing the glucose and building up their glycogen stores, which takes some time for them to acclimate once they get out of their mom's blood supply. Levels as low as 20 mg per deciliter can occur without clinical signs. Common causes of hypoglycemia, transient. So if they're premature, if the mom had diabetes or gestational diabetes, maternal toxemia, or onset in early infancy, inborn errors of metabolism. Ketotic hypoglycemia typically follows fasting or febrile illness. Adult hypoglycemia symptoms suggestive of hypoglycemia are common, but hypoglycemia is rare. So true hypoglycemia usually indicates serious underlying illness and may be life-threatening. Symptoms usually begin at the plasma glucose less than 55 mg per deciliter, with impaired CNS function less than 50 mg per deciliter. It may be due to decreased hepatic synthesis of glucose or increased glucose utilization. There's over 100 different causes. Drugs, the most prevalent drugs that would cause this would be antiarrhythmetics and salicylates, ethanol, liver failure, insulin-producing pancreatic tumors, septicemia, and renal failure. And there's many other reasons why someone could be suffering of hypoglycemia. Postprandial hypoglycemia, typically induced by drugs or antibodies to insulin or the insulin receptor, or inborn errors of metabolism. Reactive hypoglycemia or functional hypoglycemia. Idiopathic means that we don't know what causes it. So idiopathic clinical disorder with postprandial symptoms occurring in everyday life accompanied by blood glucose less than 45 to 50 mg per deciliter. Postprandial refers to after a meal. So symptoms would occur 1 to 3 hours after a meal. It is an infrequent disorder and demonstration of hypoglycemia with concurrent symptoms. Whipple's triad is defined by low blood glucose with typical symptoms alleviated by glucose administration. Normal blood glucose at the time of symptoms excludes the possibility of it being hypoglycemia. These values of blood glucose that I've been mentioning are going to be important not only for this class but also the qualifying exam. So you should make note, like, when do we have impaired CNS function? When do we start to see symptoms associated with hypoglycemia? So diabetes mellitus. So far we've talked about where glucose comes from, how glucose participates in the metabolic processes of the body and of the cells. Then we talked about hypoglycemia, where blood glucose levels are too low. And as I mentioned, that's pretty rare. True hypoglycemia could be due to inborn errors of metabolism, but all in all, it's pretty rare to have that low of blood glucose. Sometimes patients that are diabetic that happen to take too much insulin can slip into that hypoglycemic range and start to have neurological symptoms of that. But now we're going to talk about the opposite end of the spectrum. So diabetes mellitus is when we have severe or prolonged hyperglycemia, so too much blood glucose. So diabetes mellitus is a group of metabolic disorders of carbohydrate metabolism in which glucose is underutilized, and that leads to hyperglycemia. There is a different type of diabetes that we are not going to get into in this lecture, and that's diabetes insipidus. So causes similar types of symptoms of polyuria and polydipsia, so excessive thirst and excessive urination, but that's not associated with carbohydrate metabolism. So that's a whole separate disorder. We are only going to focus on diabetes mellitus and the different types of diabetes mellitus. Epidemiology of diabetes, 10.2 million diagnosed cases, perhaps as high as 15 million during the same time. Prevalence increases with age, and there is a racial predilection by 65 years of age. 33% of Hispanics, 25% of blacks, 17% of whites are diabetic. It's estimated to cause 150,000 deaths annually. Classification of diabetes. So type 1, autoimmune destruction of the beta cells. Type 2, beta cell failure and or insulin resistance. Other types include the genetic defects of beta cells, rare insulin resistance syndromes, diseases of the exocrine pancreas, so endocrine diseases, drugs and chemically induced diabetes, infections, rare syndromes with the presence of anti-receptor antibodies, diabetes accompanying other genetic diseases, and then there's the diabetes that happens during pregnancy. So any degree of glucose intolerance diagnosed in pregnancy. Type 1 versus type 2 diabetes. Type 1, the onset is usually below 20 years of age, while type 2, you usually get it over 40 years of age. There are always exceptions to this, but in general, this is what we typically see. Insulin synthesis. In type 1, there's no insulin synthesized. The immune destruction of beta cells leads to no insulin. In type 2, insulin synthesis is normal. Combination of impaired B cell function and insulin. Plasma insulin concentration, low or absent, and in type 2, low, normal, or high. Genetic susceptibility. There is an inherited association with the HLA antigens for type 1. It is not associated with HLA inheritance, but there is an important polygenic inheritance predisposition in type 2. So type 2 sometimes is more commonly related to obesity, and the polygenic inheritance of obesity can contribute to type 2 diabetes. Islet cell antibodies at diagnosis, so yes for type 1, no for type 2. Obesity is uncommon in type 1, but it is very common in type 2. And ketoacidosis, type 1, yes, it's very common. So if you're ever asked a question like when or which type of diabetes is ketoacidosis more likely to be associated with, that's going to be type 1 diabetes. Type 2, it can happen possibly after major stressor, but it's really not that common. Type 1 diabetes mellitus, going into a little bit more detail here, it results from cell-mediated autoimmune destruction of the pancreatic beta cells. Loss of 80 to 90% of the beta cells is necessary for diabetes. Alpha, delta, or other islet cells are preserved. Chronic inflammation of the islets, insulinitis, production of autoantibodies. Complex genetic inheritance. And there's various environmental factors. Certain viruses, chemicals, and cow's milk may be associated with the development of diabetes mellitus type 1. Type 2, there's two pathologic defects. One, decreased ability of the insulin to act on the tissues. So insulin is produced normally, but for whatever reason, there is no interactivity with the tissues at the level that's appropriate. So insulin resistance or a primary underlying defect can lead to that. Beta cell dysfunction. So the beta cells are not being attacked by your own immune system. That would be in type 1. But with beta cell dysfunction, it causes the inability to produce enough insulin to compensate for insulin resistance. Hyperglycemia renders the beta cells increasingly resistant to glucose, so glucotoxicity. Selective glucose unresponsiveness, loss of glucose-induced insulin release. Results from a combination of genetic and environmental factors, nearly 100% concordance with identical twins. Racial differences, as we mentioned previously, Hispanic Americans are much more likely to get it. Then comes African Americans and then white. Diet and exercise are important factors. So 60 to 80% of individuals with type 2 diabetes are are obese. Fewer than 15% of obese individuals will develop type 2 diabetes. Insulin resistance. So decreased biological response to normal circulating insulin. So one of the premises to that diet I mentioned, intermittent fasting, is that if we eat breakfast, lunch, and dinner and we're constantly stimulating insulin production and insulin release, then eventually that could lead to the development of insulin resistance. Now, there is no hard evidence to this. There's just a lot of theories and a lot of unrelated studies that kind of illuminate this could be a real potential. But with intermittent fasting, you are not eating for a prolonged period of time. And when you don't do that, then you're not stimulating the release of insulin. Now, some people will replace natural sugar with sucralose or aspartame or other types of artificial sweeteners because they know that those artificial sweeteners do not have any caloric value. While calories are one contributing factor to diet and exercise and weight gain or weight loss, it's not everything. Insulin also plays a major role in whether you're going to gain or lose weight. So if we have something that's calorie free, we think immediately that's good, but those artificial sweeteners do stimulate the release of insulin, just like consuming regular sugar. So if insulin is getting stimulated, the production, and it's getting released regardless, that can contribute to the development of insulin resistance. So something to keep in mind as you start thinking about replacing what you eat in your diet with artificial things and more processed things. You want to try to avoid those artificial sweeteners. You also want to try to avoid added sugars, because if we're adding sugars to our foods, it's also something that can stimulate more insulin release. And that can lead to this insulin resistance. Obese, non-diabetic individuals or type 2 diabetics. The manifestations include cardiovascular disease, hypertension or high blood pressure, polycystic ovary syndrome, so lots of cyst forming on the ovaries, non-alcoholic steatohepatitis, or non-alcoholic fatty hepatitis. So steato refers to fat, so that's why in the second term they put that term fatty in there. But non-alcoholic fatty liver disease is not caused by alcohol. It's some other cause that's causing fatty tissue to accumulate around the liver. That is irreversible damage to the liver. So if you have that steatohepatitis, you have fat accumulating around the liver, if it's due to alcohol, stop drinking and it won't get worse. But if it's not due to alcohol, if it's due to this insulin resistance, it's something really tough to manage. So diet, exercise can prevent that from progressing to be even worse. And then metabolic syndrome. The diagnosis of insulin resistance, you look at insulin, but it's challenging to interpret. So fasting or in response to glucose, you can take a look at those levels, and then you can measure C-peptide. So insulin resistance, inadequate insulin response, that's type 2 diabetes. It can lead to retinopathy, nephropathy, and neuropathy. Retin refers to the retina of the eye, so vision impairment. Nephropathy refers to the nephron tubules in the kidneys, which filter out your urine and help reabsorb the good nutrients that you need to keep in your body while expelling waste through the urinary system. So that's basically urinary disease. And what causes that is you start to have a lot of glucose accumulating in those nephron tubules, and that can clog up that system and even cause the death of those nephron tubules. Or neuropathy. So glucose accumulating around your neurons, small amounts of glucose is needed. Excessive amounts of glucose tends to slow things down. It can interfere with the movement of ions into and outside of your neurons, and that slows nerve impulses. So that can have some major impacts there. Compensatory hyperinsulinemia can lead to insulin resistance syndrome, which can cause hypertension, or high blood pressure, stroke, and then PCOS and NAFLD. And both of those can lead to cardiovascular disease, or CVD. So there's different types of insulin resistance. It can happen at the pre-receptor, the insulin receptor antibodies, and an abnormal molecule, but this is rare in diabetes. At the receptor, a decreased number or affinity of the insulin receptors. It's not important in diabetes. Post-receptor, defects in signal transduction, so defective tyrosine phosphorylation, reduced IRS1 levels, decreased phosphatidylinositol 3 kinase, decreased activity of key enzymes such as pyruvate dehydrogenase or glycogen synthase. And that's the most probable site of insulin resistance in diabetes. Glucose transport, so deficient or defective glucose transporters, that's yet to be established. The long-term consequences of diabetes: autonomic neuropathies, diarrhea, impotence, diabetic foot, peripheral neuropathy and ischemia, foot ulcers leading to amputations, retinopathy, visual impairments and blindness, macroangiopathy, coronary heart disease or peripheral vascular disease, nephropathy, renal failure, many of those I've mentioned already, and the assessment of a diabetic patient: blood glucose and hemoglobin A1C or glycosylated hemoglobin, an eye examination, serum creatinine and urine protein, microalbuminuria, neurologic examination, ECG or echocardiogram, and serum lipid levels. Gestational diabetes. So it's transient glucose intolerance that occurs during pregnancy. It develops in 4% of all pregnancies in the United States, but 40% go on to develop type 2 diabetes later in life. Screening for gestational diabetes mellitus happens between 24 to 28 weeks for those at high risk. So with gestational diabetes, it's usually when the mother gains a significant amount of weight, or gaining a significant amount of weight leads to the increased likelihood that they're going to have gestational diabetes. This isn't the only factor. There are some moms that don't gain any weight and still end up with gestational diabetes somehow, or gain very minimal amounts of weight and still end up with this. When it says 40% go on to develop type 2 diabetes later in life, not only the mom is at risk, but also the baby. Risk factors for the mom include age 25 and over, less than 25 and obese, history of diabetes in a first-degree relative, belonging to an ethnic racial group with a high prevalence of diabetes. Complications include perinatal morbidity and mortality, increased rate of cesarean delivery, or chronic hypertension.